Hi guys, this is another video again. We are going to discuss about the histopath slides of pathology. Almost about 65 slides we are going to discuss, with each slides important microscopic features and maybe one or two gross features and special stains used to describe those features will be discussed, starting from kidney cloudy change till squamous metaplasia cervix. All slides will be discussed in a concised manner, showing the diagrammatic counterpart and also some manual overview of the diagram. So yes, now let's begin. So the first slide we are going to discuss is cloudy change kidney. It is basically a renal change which mainly involves the proximal convoluted tubules. The proximal convoluted tubules show small, clear, well-defined vacuoles. So these are the PCTs, which shows small, clear, well-defined vacuoles as can be seen here. These vacuoles show hydropic change, means they are clear and watery in nature and they do not stain for fat or glycogen. Therefore, we cannot use Sudan 3, 4, Aldred or stains for their staining. And also, another important feature is that the microvasculature in the renal interstitium is compressed due to swollen tubular epithelial cells. These epithelial cells are more in size than the normal epithelial cells. As you can see, the normal epithelial cell and swollen tubular epithelial cells, the difference between the two, and they compress the microvasculature around it. As you can see, the microvasculature over here is compressed because of the swollen tubular cells. This is the view which can be seen in the microscope. Swollen tubular cells, compressed capillaries, and clear vacuoles in the cytoplasm of the PCTs. The next one is fatty change liver. Fatty change liver basically occurs in hepatic steatosis. Hepatic steatosis means because the lipid metabolism which takes place in the liver gets hampered. Let it be because of accumulation of the triglycerides in the liver, decreased conversion of triglycerides into lipoproteins and their excretion from the liver through the transporters, and also decreased conversion of triglycerides into other derivatives. Because of these reasons, fatty change mainly occur. That was basically about the pathology. But what microscopic features we see? Fatty change is there. Therefore, special stains like Sudan 3, Sudan 4, Sudan black and Aldred oak can be used for demonstration. And also one important thing is fatty cyst. In this diagram, you can see the adjacent hepatocytes of the fatty change. They rupture and lead to a formation of a cyst, which is known as a fatty cyst. Also, what is this microvesicle and macrovesicles? In this microvesicle, you can see nucleus is placed centrally and the nucleus is placed peripherally in the macrovesicles. This is because, as explained over here, that fat forms a minute droplets in the cytoplasm, and here the fats form the coalesced droplets, because of which these two changes are seen. Rest are the important features like portal, triad, central vein remain as it is, but the important three features are microvesicle, macrovesicle and fatty cyst. The third basically microscopic diagram we are going to see is leiomyoma uterus. Leiomyoma, it suggests that it is the cancer, or it is the basically proliferation of leiomyoma, means smooth muscle cells of uterus. So basically in this proliferation, what are the important features we see? As you can see in this diagram clearly, you can see there are a lot of smooth muscle cells present over here. Fibroblasts are there, whorls are present of smooth muscle cells and fibroblasts, and if seen minutely, keratin pearls are also seen. So what are all these we are going to discuss now. So basically this is the Hyaline change. What is the Hyaline change? Hyaline change is nothing but it is a pink. It's a homogeneous because there is no other color admixture. It's a homogeneous pink and acellular, lying at the center of the whorls, the fibroblast and the benign smooth muscle cells. Both the benign smooth muscle cells and fibroblasts form a hold pattern arrangement, and in the center of that hold pattern arrangement, you will find a hyaline change, which is a pink homogeneous acellular material lying in the center of the hold pattern. So the next one is amyloid kidney. As you can see here, the amyloid is basically a pink homogeneous deposit which is extracellular in nature, seen in three forms in the kidney. First is the glomerular form, you can see the homogeneous pink deposit. Second, the interstitial form, you can see as in this diagram, this is the basic blood, small artery, so arterioles, and the extracellular homogeneous merchant amyloid surrounding it, which has caused narrowing, which can be observed in the ear. And next is basically it lies inside the basement epithelial tubular epithelial cells as an amyloid cast, which are the main three observation which we see. And here you can see the glomerular deposit, then the basic deposit in the interstitial vessel, and this is the amyloid cast. Next we have is a TB lymph node. We will explain it in more manual manner. So this is basically the diagram. Here you see a necrotic foci which contains of a structureless eosinophilic material which contains foci of dystrophic calcification. Then you can see epithelioid cells which are slipper-like cell, Langerhans giant cells, and lymphocytes which are actually a granuloma components. Then you see viable lymphoid cell in the form of a lymphoid tissue present just above it. So this is basically the structure of a TB lymph node. The same diagrammatic manner you can see here, viable lymphoid tissue, granulomatous inflammation, and the caseation necrosis which is observed. It is less clearly seen in this diagram, but this diagram explains well. Next is acute appendicitis. The most important diagnostic feature is neutrophilic infiltration. Neutrophilic infiltration of muscularis propria. What is my muscularis propria? Basically, this is the mucosa layer where we see the necrotic mucosa, because this is acute appendicitis where mucosal necrosis occurs and the mucosa gets sloughed off and the blood vessels in the mucosal wall are thrombosed. So you can see the blood vessels, it is not clearly observable over here, but blood vessels in the mucosal wall are thrombosed. So this is the mucosal wall, and here there is a thrombosed blood vessels, sloughed off mucosa because of its get necrotic foci. Necrotic, this is the second observation. Then also neutrophils infiltration in the muscularis propria. This is the muscularis propria layer which is made up of a smooth muscle cells, and here you can see there is a minute neutrophilic infiltration in the muscularis propria. So yes, this is about acute appendicitis. Next, what we have is a pyogenic meningitis. Basically, meningitis means inflammation and infection of the meninges, and pyogenic meningitis is because of the bacteria. As the word suggests, pyogenic, it means it is going to form a pus forming. So it will be basically the bacteria which does this can be identified by routine or gram staining, and there will be a formation of granulation tissue, and also which microscopy will be discussed later. And the meninges, particularly around the blood vessel, show numerous polymorphs and fibrinous materials. So as you can see here in this diagram, the meninges which are particularly around the blood vessel, they show numerous polymorphs and neutrophilic material. So you can see these are the inflammatory exudate polymorphs and basically polymorphs and fibrinous material, and this is the formation of granulation tissue. So basically this is a diagram of lepromatous leprosy. In this diagram you can see there is a clear zone of separation between the dermoepidermal junction and the lower layer. You can see the foam cells which are present over here, and there are no lymphocytes present, congested blood vessels, glands, and also thin epidermis. So thin epidermis, congested blood vessel, foam cells, and glands are the characteristic feature of lepromatous leprosy. So yes, this is the diagram of lepromatous leprosy. Next is the skin tuberculoid leprosy. Here what you find a difference, there is no clear zone of separation between the basal layer of the epidermis and the dermis. So basically the epithelioid cell erode the epidermis, as you can see over here, and also it is a granuloma formation because they closely resemble the hard tubercles, in which we find the epithelioid cells, Langerhans giant cells, lymphocytes, a caseous nerve, and also these granuloma will erode the epidermis, as we can see here. What the difference? Previous one there were no lymphocytes. In here there are lymphocytes. Second thing, there was no granuloma, there was just the foam cells. But in here, there is granuloma as well as there is a foam cells. And you can see the epidermis over here is eroded and it's thick. Next one is 11th one, which is actinomycosis. Actinomycetes causes actinomycosis. Here you can see that the bacterial colony sulfur granule, basically it's the bacterial colony called as sulfur granule, sorry, and it is characterized by basophilic radiating filament. So these are the basophilic radiating filament, as one can see over here, basophilic radiating filament. And at these filaments end, you will see a hyaline eosinophilic club-like ends. So you can see hyaline eosinophilic club-like ends which are present. Eosinophilic club-like ends are basically seen in the center of suppuration. And surrounding it, you will find abscess, and that abscess consists of chronic inflammatory infiltrate. You can see foreign body giant cell, you can see neutrophils, lymphocytes, fibroblasts, macrophages, and mononuclear cells. Then there are multinuclear giant cells, fibroblast also. Basically this is called as an actinomycosis, which can be seen in this slide nicely. The next one is granulation tissue. So let's first discuss what are the features of granulation tissue. You will find everything. You will find fibroblast, neutrophils, lymphocytes, which shows both chronic and active acute inflammation components. You find plasma cells, macrophages. So macrophages, plasma cell, lymphocyte, neutrophils, fibroblast. You'll find an ulcer which shows eroded mucosa, and also there's a neovascularization. So you can see these features one by one. Neovascularization, then you see lymphocytes. These are the smooth muscle cells. These are the fibroblast. So smooth muscle cell, fibroblast, lymphocyte. Then this is the neovascularization. Then these are the plasma cells. You can see plasma cells, and these are the macrophages, neutrophils. These are basically all the cells which are prominently found in a granulation tissue. Next one is ileum typhoid ulcer. Here only few important things are important. Basically the triad of basically hyperemia, then edema, and next is a cellular proliferation. So triad of hyperemia, edema, and cellular proliferation, which consist of phagocytic histiocytes. Basically they show characteristic of erythrophagocytosis. So how do they appear exactly? So phagocytic histocyte appear like this. So basically it consists of, so basically this is how the erythrophagocyte appears. And though enteric fever is an example of acute inflammation, still neutrophils are invariably absent from the cellular infiltrate. You can't find any neutrophil, but you find mononuclear cellular infiltrate. Also in this diagram one can observe mononuclear cellular infiltrate is present. So this mononuclear cellular infiltrate, erythrophagocyte. Then this is basically muscularis layer, and there is prominent pairs, patches, and ulcerated mucosa. So there's a characteristic features of typhoid ulcer ileum. Next one is TB lymph node, which was same as discussed of the 5th microscopic slide. Let's move forward to next one. So the next one is CPC lung, which is called as a chronic venous or chronic pulmonary congestion lung. So what exactly occurs? CPC lung main important causative feature is right-sided heart failure, because of which in the lungs the chronic pulmonary congestion occurs. So what is observed? You can see here the morphology. So the basement membrane of the lungs alveoli, and these are basically the alveolar septa. In this alveolar septa, you will see the migration of lymphocytes which has occurred, and at the same time you see the multiple dilated blood vessels, and these dilated blood vessels will rupture and cause release of the blood into the alveolar region, which can be seen the dispersed blood, lymphocyte also in the alveolar septa, and lymphocyte also in the basic blood. And here what you see are the special type of cells which are called as heart failure cells. The microscopy is very different. So this is how is the microscopic appearance of heart failure cells. Next one is CPC liver. Let's first discuss about its pathology. CPC liver main reason is basically portal hypertension. Portal venous pressure increases, which causes the dilatation of the portal vein, then dilatation of hepatic sinusoid, transmission of pressure, which causes the dilatation of the entire basically liver. Important characteristic feature is very different. You will see in the diagram as follow. So basically CPC liver, so first you see is a portal vein like this. The portal vein is there, and in outside the portal vein the radiating hepatocytes are there. But now in the central lobular region, the radiating hepatocyte will show degenerative changes. They will show dilatation of the hepatocytes and hepatocytic sinusoid. So dilatation appears as below. So basically this is the hepatic hepatocytes we assume. So these hepatocytes, as we observe, those are completely degenerated, those are dilated hepatocytes. So dilated hepatocyte, also you see a lot of red blood cells over here, which indicates central hemorrhagic necrosis. So that is a central hemorrhagic necrosis which has been indicated over here. Basically this is the central lobular region, but now in the peripheral region the hepatocytes are normal. So the hepatocytes in the peripheral region show normal morphology. So normal morphology of hepatocytes in the peripheral region. And also what we observe is a fatty change, which basically here the hepatocyte show a fatty change. So this is the fatty change of, this is the basic histology of CPC liver. So in this diagram you can see this is basically the portal triad, which consists of the bile duct, the portal vein and the hepatic artery. This is basically the central lobular region where a central hemorrhagic necrosis has occurred. There is a degeneration of the hepatocyte, loss of the hepatocytic architecture. But peripheral the hepatocyte are normal in architecture, and those hepatocytes also show a fatty change we can be observed over here. Next is thrombus artery. In the thrombus artery, what are the important features? Thrombus artery important features are first that we know that artery have three layers: tunica intima, tunica externa, and tunica media, or tunica adventitia, intima, and media. So basically, tunica media layer is lost, or we can see the tunica media layer, which internal elastic lamina and an external elastic lamina present in between the two layers. So the internal elastic lamina is lost at the place where this thrombus is deposited. What does the thrombus consist of? Thrombus consists of basically fibroblast, which is composed of fibrin component. It consists of platelets. It consists of platelets, neutrophils, fibroblasts, and the vegetation total entirely is called as a thrombus. You can see the internal elastic lamina is lost at that side, and also the residual lumen of the original artery is slit-like and shows the flowing blood. So can you see this lumen of the artery? Basically this lumen is supposed to be a hole centered, but now because of thrombus deposition the lumen is occluded, and at the same time this residual lumen shows basically blood flowing within it. So these are two important features we discuss: basically thrombus composition, loss of internal elastic lamina, and also the lumen which consists of blood. What are the lines of Zahn? Lines of Zahn are basically those lines which are considered to be like fibrin strands. The light staining fibrin strands are there, and the platelets which are emerging dark. So this light and dark pattern are known as a line of Zahn. Okay, so basically then surrounding external elastic lamina, then surrounding smooth muscle cells, surrounding lymphocytes and fibroblast. So this basically thrombus artery which can be seen over here. Next is skin papilloma. As the word suggests, papilloma means finger-like projection. So can you see the basic skin epidermis is thrown now into the papillary folding, known as papilloma. We see three changes: hyperkeratosis, acanthosis, and papillomatosis. So basically hyperkeratosis occurs in the stratum corneum, acanthosis occurs in the stratum, we can say in the granulosum ki below layer, which is called stratum spinosum, and basically it's a hyperkeratinization of corneum, hyperkeratinization, thickening of the spinosum layer. As you know, skin epidermis has 5 layers which are called as a stratum corneum, then stratum granulosum, stratum spinosum, stratum basale. Okay, so basically the layers, and we see papillomatous changes. Three main changes are there which are seen in skin papilloma. Next is a squamous cell carcinoma. Squamous cell carcinoma is the most commonly known histological pattern of many tumors. Squamous cell carcinoma, to be briefing out, basically the most important part is this: the squamous cells, they show a lot of proliferation, and there is a downward proliferation of the squamous cell which interrupts the basically dermal layer, and also the squamous well differentiated form will form a word pattern, and then poorly differentiated form will show this downward proliferation wala pattern. And also the keratin pearls are present. These keratin pearls are basically, these are the concentric layers of calcification as keratin pearls, and this mass of tumor cells are separated by lymphocytes. So as we can see over here, the masses of tumor cells which are separated by lymphocyte, keratin pearls, and squamous cell differentiation. This is what is seen in squamous cell carcinoma. These are the keratin pearls, these are the surrounding squamous cell proliferation. Keratin pearls, squamous cell proliferation. We show the well differentiated form. Next pattern is adenocarcinoma colon. Adenocarcinoma colon, basically talking about the gross features, these consist of multiple type. Like in left sided we see basically polypodal or cauliflower like growth pattern. In right sided we see basically fungating, or we can say there is then the infiltrating growth pattern is there, napkin ring appearance in right side, and also we see one infiltrating pattern, then one is a ulcerated pattern with indurated margins. But basically about the gross pattern. But talking about the microscopic pattern, what we have are the malignant gland. Basically this malignant gland are basically infiltrating in the carcinoma, and these are the mucin pools which can be seen, which are stained off, which are basically 10% of cases shows mucin secreted colloid carcinoma with pools of mucin. You can see the muscularis propria which is completely invaded, and malignant gland. This is the microscopic feature of adenocarcinoma colon. Next one is basically capillary hemangioma. Now we will discuss two important hemangiomas, which are capillary hemangioma and cavernous hemangioma. So what is there in capillary hemangioma? Basically important things. First thing, in capillary hemangioma, what we observe? What we observe are basically these lobules of capillaries. Means what happens exactly? The lobules are composed of capillary size thin walled blood filled vessels. So these are the lobules. These are multiple lobules which are composed of capillary size thin walled blood filled vessels, and inside the lobules these are lined up by plump endothelial cells, and surrounding the lobules, between the lobules, the interlobular space is composed of a lot of fibroblasts, a lot of stromal component tissue. So stromal connective tissue, fibroblasts, lymphocytes can be observed, and plump endothelial cells, and the lobule consists of capillary sized blood vessels. This is the characteristic feature of the capillary hemangioma. Next one is the cavernous hemangioma. Why it's called cavernous? The word cavernous suggests that it is basically, it is incompletely or it is inappropriately shaped. It is not properly shaped. These are cavernous spaces which are completely or partially filled with blood. Therefore, they are called as a cavernous spaces. And the vascular spaces are lined by flattened endothelial cells. We can see these vascular spaces are lined by flattened endothelial cell. Here you saw is a plump endothelial cell, and this is the flattened endothelial cells. And the intervening stroma consists of scanty connective tissue. Here there was a dense connective tissue. Dense connective tissue, scanty connective tissue, no plump endothelial cell but flattened endothelial cells, cavernous space which are completely filled with the blood vessel, and here are lobules which are filled with the blood vessel, and they are surrounded by stromal fibroblast. So this is basically two capillary. This is cavernous hemangioma. You can see cavernous spaces, flattened epithelium, scanty connective tissue. Next is a benign cystic teratoma. As teratoma was discussed in my previous video, teratoma is basically all the three layers of differentiation, which are basically endoderm, ectoderm, and mesoderm. All the three maturation component of adult maturation component, they appear. This is dermoid cyst. Basically, it occurs in ovary. Here you can see all type of maturations. You will see smooth muscle cell, fibroblast. Then these are the basically squamous, stratified squamous lining. These are glands, intestinal gland. You will see smooth muscle. See adipocytes. These are basically intestinal epithelium known as a columnar epithelium. And this is the cartilage. This is different maturations coming from ecto, endo, and mesoderm. Next, this is chronic peptic ulcer. This is very important. So basically, this is the chronic peptic ulcer. Chronic peptic ulcer, the most important feature is punched out lesion. Means basically what? The base will be smooth. The base won't be necrotic or indurated, or margins will be normal margins. Base will be smooth, but punched out lesions will be there, and there will be more kind of superficial. So basically, you can see over here that this is basically the early granulation tissue which is formed. Then there will be a smooth muscle proliferation. You will find the adipocyte proliferating and fibroblast proliferating, which are seen as an important thing. Now, chronic peptic ulcer is, you can see ulcerated margin, loss of mucosa. Then you see that one of squamous, basically of teratoma. This is of chronic peptic ulcer. Ulcerated mucosa, a lot of neutrophilic infiltration. Then you see the basically the important cells which are granulation tissue component and fibroblast proliferation. So same thing is seen over here. Necrotic zone, ulcerated mucosa. Basically below the is ulcerated mucosa, you will see the neutrophilic infiltration. So necrotic zone, the superficial exudative zone. This consists of basically lymphocytes, neutrophilic infiltration. The third zone is the granulation tissue zone. You will see everything. You will see the congested capillaries, lymphocytes, neutrophils. You will see fibroblasts. You will see Langerhans and granulation tissue, neovascularization, lymphocytes, plasma cells, macrophages, neutrophils, monocytes, stromal cells. Then will be a fibroblasts, smooth muscle cells, everything of the granulation tissue component, and below is a proliferating fibroblast, basically known as a zone of cicatrization. So four zone. First zone known as necrotic zone, coagulative necrosis is seen, eosinophilic smudgy appearance. Then superficial exudative zone, fibrinous exudate, leukocyte, neutrophil. Granulation tissue zone, chronic inflammatory infiltrate, and last is zone of cicatrization, dense fibrocollagenic scar tissue. Next one is the viral hepatitis. The viral hepatitis is basically, you can see over here, important features. First is it occurs because of hepatitis A, B, C, D, E, and also Epstein-Barr virus to be observed. What important changes we see? Ballooning degeneration, that is hepatocyte balloon themselves, and then there if you see a dropout necrosis, you can see totally the eosinophilic content is lost, dropout necrosis. You will see Councilman's body, which are acidophil bodies. What are Councilman's body? Councilman's bodies are basically identify eosinophilic cytoplasm and pycnotic nucleus. Two important feature: eosinophilic cytoplasm and pycnotic nucleus. Then you see inflammatory cell infiltrate, like you will see glands, lymphocytes. So as you can see in this rough diagram, these are basically dropout necrosis, ballooning degeneration. Then there's the inflammatory exudates and multiple glands. This is the acidophilic Councilman's body, which are the characteristic features. Here in this diagram, you can see clearly. Second last one which we have is portal cirrhosis. Portal cirrhosis suggests, as the name suggests, it will be of macronodular and micronodular pattern. So basically you can see the fibrous septa, which is infiltrated by lot of fibroblastic stromal cells, infiltrated by lymphocytes, infiltrated by these glands, and these glands are nothing but a bile ductular infiltration. You can see bile ductular infiltration, lymphocytes, lot of stromal fibroblasts. There are two patterns: fast fatty change, which are observed in the hepatocyte. There are uniform sized micronodules surrounded by fatty change. There is a basically macronodular pattern, ductular proliferation, fatty cyst, and stromal fibroblasts, which are the characteristic feature of portal cirrhosis. So here in this diagram you can see micronodular pattern, fatty change, bile ductular proliferation, and scanty stromal cells. Next and the last one which will be covered in this video is lobar pneumonia. So lobar pneumonia, basically we see like lot of stages are there. First is the basically normal congestion stage, then gray hepatization, red hepatization, and last is the regeneration stage. So basically you can see over here a clear space is present between the cells and the fibrin stand. Macrophages are present, then you will see some polymorpho mononuclear cells, polymorphomononuclear cells, macrophages, lymphocytes. We'll see a clear space between the septal wall from the cellular exudate. So cellular exudate and septal wall has a clear space in between them. Then you find the congested blood vessels. Yes, this is basically morphology of lobar pneumonia. Stage of congestion, macrophages and polymorphoneutrophils, basically suggesting stages of congestion and red and gray hepatization, clear space. So that is shown as gray hepatization, lobar pneumonia. So yes guys, these were the 30 slides which are covered in this video. Still more 35 slides are left which should be covered in next series of this video. I hope you enjoyed the lecture not, but basically the brief explanation and important microscopic feature which I discussed in this video. It was a sincere effort by me again to put in all my pathological like practice and knowledge into a great explanation. I hope you enjoyed all, and just keep viewing more and more videos. Thank you so much.